afternoon, everybody. Before we start, just like to take a quick photo. If you'd all wait for me. Great. That's just so that my kids know people do listen to me. Okay, I'm going to talk to you today about heroin-assisted treatment, or diamorphine-assisted treatment, as I tend to refer to it now. There we go. So, the first question I often get asked really is why we looked at diamorphine-assisted treatment in the Middlesbrough area. And it becomes fairly obvious when you start to look at some of the information. So Middlesbrough is an area of extreme deprivation. So over 50% of the wards in Middlesbrough are classed as deprived and include some of the most deprived wards within England. We also have a significantly higher percentage of people who use heroin than the rest of the North East and the rest of England. And sadly, we are always there or thereabouts in terms of drug-related deaths. So we have a real perfect storm in terms of toxic conditions, really, that mean that we have a group of people that are dying prematurely because of their substance use. And there are people who survive, who are actually in extremely poor health. So the average age of some of the people that we're working with is about 42 years old. But they present with really staggering prevalence of chronic health conditions. So they're twice as likely to have respiratory problems like asthma and COPD. They're twice as likely to have significant problems with mental health. And I can honestly say within this group, and I'm sure the clinicians amongst you will recognise this, that all of the patients that I've been working with have had singular or multiple episodes of trauma in their lives. They're 50% more likely to have a stroke. We have huge levels of skin infections. Amputees is becoming fairly common, sadly, in this group. And they're twice as likely to need palliative care. The average age of this group of people is 42 years old. So we're looking at medieval levels of life expectancy in this group. People are presenting with the traumas of their childhood, but with the illnesses of old age. So we wanted to do something different. I won't spend too much time on this slide other to say that there is a huge amount of evidence in terms of the role of heroin or diamorphine in treatment of people who are failing to benefit from traditional treatments like methadone and buprenorphine. And the trials have happened across the world, and they're written in our orange guidelines, the drug dependency guidelines, in terms of best practice as a second-line treatment, a second-line intervention, which is normal practice in medicine. If people present with a problem that isn't addressed by the first medicine, we move on to the second medicine. That doesn't happen in substance use as readily as it needs to. So, what did we do? So we started looking at this at about 2017, and we went live in 2019. We were originally funded by the Police and Crime Commissioner. That changed, and we were later funded by Project Adder, which some of you may or may not be aware of, which is additional government funding for areas that are blighted with drug-related harms, particularly deaths. It's an integrated programme, so we situated the service within a specialist GP practice. Literally 2 rooms of that practice are taken up with the delivery of diamorphine-assisted treatment. 1 room for the preparation of medicines and 1 room for the observation of the injection. People attend twice daily, or did attend twice daily, once in the morning, once in an afternoon, and then they were able to either engage with psychosocial interventions or go about their days. We operated for 3 years, and we stopped operating in December 22, but I'll talk a bit more about that later. So if this works, there should be a video. It's like a shit MTV Cribs, but we'll have a go. The idea to look at heroin-assisted treatment in Middlesbrough really came about by seeing people who were struggling with substance use and some of the adversities that they were facing, and knowing that there were other ways to approach this problem. So when a patient's ready for their dose of diamorphine, we take them down to the injecting room.
So it's been a long process to get to this point, and it started really with conversations between myself and the local public health team, and that partnership widened to the office of the Police and Crime Commissioner. They'll choose a booth to sit at. Most people have got a booth of their own personal choice, and they'll wait there until the medication is prepared and brought to them. We all understood that this was an intervention that could really potentially make a big impact on the individuals that would access the programme, but also on reducing the impact of that problematic substance use for the wider community. I think the biggest surprise has been the speed of the impact of the intervention, really. I think probably the most significant is the impact on crime. So we know that an individual's substance use, if that is stabilised, they no longer need to engage in criminal activity to fund their chaotic drug use. We've seen transformation on many levels. We've seen individuals who've gone from that kind of chaotic picture of substance use to getting their first flat, to getting engaged, to starting to learn how to manage their own finances. We've often hear the rhetoric of the war on drugs. The people who are users of substances are the victims in this war, and for me we need to take an evidence-based approach to drug policy. We know that driving a car is dangerous, but we don't just ban all cars or create a war on cars. What we do is we make that activity as safe as possible. We need to look at a regulated market which is based on the risks that a particular substance has and the safety needs that need to surround that substance to keep people safe.
Sort of key areas, the treatment benefits, the clinical challenges, and then the external barriers to delivery. And these were interviews that were undertaken with the staff who were working day to day within HAT. And I won't read all of these out, I'll just pick a couple of the quotes. So one here, I've seen people's lives change. I feel very privileged to have been around people and to get to connect with them more. It's been a real privilege and an access into people's worlds I just wouldn't have ever been able to get. The inverse care law was a term coined, meaning that people who need the care most get the least of it. I think the HAT's managed to turn some of that around. They went on to talk about some of the challenges. This was not all a bed of roses. It was a very complicated treatment to deliver and had some real challenges in terms of people turning up intoxicated at times. We had a guy turn up the other day and he had some blue around his mouth. I don't know if that's familiar for you guys, but certainly in Teesside, Zopiclone is a drug that's used that leaves a blue residue, like lipstick around the mouth. So this person had presented with that. He'd obviously taken some Zopiclone and was quite disorientated. He denied all drug use, but we knew he'd taken something and he was sent away. And he came back later the next day and apologised and said, yeah, you were right. We had another incident where there was a patient who got really annoyed because he couldn't find a vein, and he threw his needle in the booth and it kind of bounced back. If that would have hit one of us as staff members, it would have been horrific. So real challenges for people in terms of just the day-to-day delivery of this medicine and the stress that people can experience. And the external barriers to delivery that they identified. We were under quite a lot of public scrutiny at the time, and the staff talk about that here. So people are watching us, the neighbourhood is watching. They turn up and they take little video clips on their camera phone and they try and upload them to social media and things like that. So we had a period of time where we had to protect the patients in terms of people trying to film them coming to and from the clinic, and also trying to film the staff. And any untoward incident that happened in the local community was filmed and then directed to us. So we were lucky enough to be able to say that isn't one of our participants, and we were able to show police data that showed an actual reduction of crime in the area rather than an increase that was being blamed on the patients who were in the programme. This next quote is about when the team heard about the funding being withdrawn. We first heard about it that the commissioning partner, the PCC, Steve Turner, if you want to email him and let him know what a bad decision that was, wasn't going to continue the funding. I had to hear about it on BBC Breakfast. Wow. These are people's lives that he's talking about, already vulnerable people. There was obviously just no comprehension of what making that announcement on public television without telling us first would have. So, again, I think this just really shows the sort of lack of regard for the people that were attempting to, were dramatically able to stabilise their lives. We evidenced that, we shared that evidence, and it was not heard. But the staff really felt this pressure on a day-to-day basis of being under attack. The next paper is called This is Hardcore, and this is the service user perspective, and I think that really sums it up. This is a really difficult thing to take part in. It asks a lot of you in terms of your attendance and your commitment. You know, Christmas Day, if you need to be in and have your doses, if that's what you choose to do. Easter Sunday, when it's snowing outside, you've got to get there twice to kind of get your medicines. And that was really, it sort of comes across in some of the comments. These papers, the key themes were sort of broken into two, really. There were the initial worries about the demands of the programmes, and then people's desire for change. And I'll look at these first. So these are looking at the worries, really. There's still a few people out there who think I would need this help, but they're dead wary of it, because they'll have loads of addictions to tablets and something else, or crack, or they're heavy drinkers. I get breathalyzed every day, so that's why people say I don't want to bother, because that to them is the type of hurdles that they need to get over. You know, one about the funding. How long is it going to be funded for? What happens if the funding goes and I'm left back on the street? I'm probably going to end up back in jail. My future is basically in the hands of HAT. So really understandable worries about the commitment that's needed, and you know, faith in us as providers and clinicians and as a society to look after this group of people. And these were about desire to change. So again, this was some of the motivating factors that people considered when thinking about joining the programme. I was in and out of hospital a lot with my breathing because of the heroin. I was injecting in my veins, so my veins were blocking the oxygen, and it got really bad, really bad. I nearly died once. I was so desperate to get on this course because I wanted to stop. I wanted to get off the merry-go-round. I wanted to be off everything. I wanted to clean, again, I don't like that word, but that's somebody else's, healthy life. I want to be rebuild the relationships and enjoy the rest of my life. So you can really feel the tussle in those different quotes of, I really want to do this, but I'm worried that I can't, and I don't necessarily have faith that people can deliver this for me. The next sort of two slides and themes were really about, can I adhere to this treatment? Can I commit to this on a long-term basis? And what the challenges of that like? Again, versus the sort of support and destigmatisation that people felt within the programme. You know, the first quote, I think the most annoying part is coming twice a daily, especially where I have to live. That's the only thing. I have to get 4 buses to get here, and home then 4 buses to get here, so that's 8 buses a day. So there's a real challenge in terms of being able to get in. And because I'm on HAT, the downfall is I'm bumping into people, you know, because the place where I'm coming to, I'm bumping into others, and I maybe go off with them sometimes. I've relapsed 3 times in the first year because of tablets and found myself in a dodgy place. So our job, our hope was to integrate people into the treatment system, but for some that was also a barrier because they were still around people who were at different stages of their own journeys. Just to add to these points, if we would have been able to continue the programme, we were planning to develop to move towards oral preparations, nasal preparations, and also take-home doses, just like we used to have with the old British system. For me, this is not the ideal way to deliver this treatment intervention, but it's the only way you can do it within England right now. You won't get a Home Office licence to provide that in the old school way. And so this is about the sort of experience of HAT and the real positives that people felt. I feel good. I feel people see me for it says what I am. I think it means who I am, and that there's nothing wrong with that. They're really nice in there. They let you get on with it. They watch you to make sure that you're not hurting yourself or you're not going in places you shouldn't be. So we don't allow injecting in the neck or the groin. But they do watch over you. They don't crowd you and they don't stand over you a lot or anything. I've got a good bond with the staff in here, and Hat's made a difference. It's like you get closer with the staff, like me and staff member, we get on as always sisters. That's how close our bond is now that I'm on this programme. I'll miss this slide.
Oh.
And just come to the end, the last slide. Sadly, we closed, and we closed for a number of reasons, which I'm going to go into here. So the service was terminated in December 2022, and the funding was cut, and it wasn't a huge amount of money. So we often get, it was more expensive than opiate substitute treatment, and it works out about £30,000 per person per year. So it's not a huge amount of money to get somebody in this programme and sustain them if you use an integrated model. But we're in a sort of backdrop really of a drugs system that is not fair and is driven moralistically. So we've got a drug strategy that wants world-class parameters, but it's world-class treatment, sorry, but it's got parameters. It's driven ideologically and it's blinded to the evidence. So why don't we have overdose prevention centres? Why don't we have broad access to Diamorphine Assisted Treatment? There are strong evidence bases for this, and I think that for me is because people take a moral sidestep and it sits uncomfortably with the current government that we've got. And we've got a PCC that said he saw no evidence of crime reduction. I've shown you the evidence. We were able to show that independent evidence that there was crime reduction. We had a Minister for Drugs at the time, Kit Mulhouse, who actually tweeted, "I want to inoculate drug users." I mean, what the fuck? This is unbelievable. This is out there on Twitter that our Minister for Drugs at the time was wanting that kind of approach. So when you're pushing against the tide of that moralistic kind of sidestep, it's impossible, or it's very difficult to continue a service like this because nobody was prepared to see the evidence. There's about £900 million worth of investment in drug treatment in England right now through Carol Black. At £30,000 per person per year is a drop in the ocean. So you will hear that this programme failed, that it's been shut down because of its failure. Do not fall for it. The treatment hasn't failed. The people who access the service haven't failed. The people who access the service have been failed. Commissioning has failed, and people who need this life-saving medication have been failed. Thank you very much.